much, Giacomo. Good morning, ladies and gentlemen. I try to recapitulate in the next 20 minutes or so some of the basic principles that are behind the pathophysiology of the acute respiratory failure and RDS. This is just a few physiological reminders. You know that when we breathe, we respond to a very simple physical principle, which is the proportion between the pressure and volume, and as soon as the gradient is created by the inspiration between the atmospheric pressure and the pressure which is in the alveoli, we can just inhale air, and exactly the opposite occurs when we exhale. Just a reminder concerning the carbon dioxide, which is important to keep in mind that is a function of the metabolic production on part of the patients and inversely correlated to the flow that passes through the system, that in this case is the respiratory system. Remembering that the alveolar minute volume is indeed the respiratory rate times the effective tidal volume, and the effective tidal volume must be calculated as the tidal volume subtracting that space. The dead space is composed by the anatomic and physiological part. Very essential things. The oxygenation, in large part, is related to the alveolar partial pressure of oxygen that is the driving pressure for the gas exchange across the alveolar barrier. And then the PaO2 is indeed calculated through the formula represented into the slide between the atmospheric pressure minus the water vapor pressure times the VO2 minus the PaCO2, and the quotient ratio is the denominator. And it is very important because these represents the matching to the alveoli ventilated of the perfusion. The abnormal gas exchange are in large part due to two main principal reasons. The hypoxemia that can be due to hypoventilation, to the mismatch of the VAQ, to the shunt or the diffusion impairments, or hypercarbia that it is due to hypoventilation and again to the VQ mismatch. Just a very brief mention on the effects of mechanical ventilation on the respiratory systems, because all the major principal details will be touched by Giacomo immediately after my presentation. In general, when you apply mechanical ventilation, you have an improvement of the VAQ. You have reduction of the elastic wall load and reduction of the resistive wall load. And in certain patients, at least those patients who have COPD, excuse me, you may just interfere with the threshold workload due to the PPI. And the hemogas analysis in general improves in terms of PaCO2 and PaO2, in large part related to the fact that we act on the alveolar ventilation and the inspiratory force, the oxygen consumption, and the CO2 production, ultimately resulting in a reduction of PaCO2 or an improvement or amelioration of PaO2. Due to the fact that the inspiratory effort is reduced, the oxygen consumption is reduced, and the mismatch is improved. However, I want to focus and to draw your attention on the one of the major determinants of the respiratory failure, which is the acute respiratory stress syndrome. There has been published recently a beautiful review into the JAMA, and Eddie Fana and Slasky Eddie Brody are the authors, where all the various aspects of the RDS from the diagnosis to the treatment are recapitulated. Just to give you some figures concerning the epidemiology. These are relatively old data, but indeed well depict the situation. We may have something like 75 per 100,000 patients as the incident of the acute respiratory failure, but there are also different incidents reported into the literature. And this is a quite huge and quite large representation of this pathology in patients admitted to the ICU. The major risk factors are a direct lung injury, such as pneumonia or the aspiration of gastric content, or the indirect lung injury. Common causes are sepsis. It's well known that also peripheral sepsis located, for instance, into the abdomen may cause in the lung the injurious insult. And then the severe trauma with shock and multiple transfusions may be also another issue. There are also less common causes, fat emboli, pulmonary contusion, or inhalation injury may be some of those causes. Or you may also have some situations related to the cardiopulmonary bypass, drug overdose, pancreatitis, and so on. But in essence, anatomopathologically, what is behind the ARDS, and this is the real classical definition, the best way to just identify the ARDS is diffuse alveolar damage. The real matter is that the diffuse alveolar damage to be diagnosed should need a biopsy, and you can imagine that this is not very practical at the bedside for many different reasons and implications. However, in a beautiful study published by the group of Andres Esteban, there was a comparison of the new definition of ARDS with the results of the autopsy of patients dying with or for or due to the ARDS. And in these, looking at the clinical criteria, the real representations of the diffuse alveolar damage into the various categories of severity of the disease may be quite different. And the more severe is the syndrome, the highest is the possibility that the final anatomopathological results coincides with the real presence of ARDS. However, looking at the sensitivity and the specificity of the diffuse alveolar damage and the clinical, in comparison to the clinical definition, we may realize that the clinical definitions respect to the real presence of the anatomopathological alteration is indeed weaker with a lower specificity and sensitivity. But let's have a look together to the reason why we can see at the bedside the different physiological alterations and how these can be related to the anatomopathological alterations. I will show a picture and then I will exploit the help of a cartoon. When you have patients with ARDS, you have the bilateral opacities with several densities, and at times you do have some thickening of the interlobar septa that is consistent with the presence of pulmonary edema. And then often, like in this case, you may also see some bilateral pleural effusion. One thing that you have to keep in mind that is in this area, the VQ is low, and there is a sort of alveolar flooding over there. And the presence of the edema may just compress other part of the lung, causing atelectasis and inactivation of the surfactant. But at the same time, in the upper part, in the of the lung, in the part that are not laying on the bed, you may see an high VQ ratio that where there is an increased ventilation and at the same time the effect determined by the hypoxic vasoconstriction. Not only that, the vasculature can be indeed altered, and with respect to the normal condition that is represented into the picture by this extended network of vascular capillaries, can be indeed very rare now and minimized. However, as soon as you look at the development of ARDS, we have to keep in mind several moments, which are the inflammation, coagulation, the modulation of the immune response, and the tissue repair. One thing that is important to keep in mind is also that normally in our alveoli, we do have, if you perform a bronchoalveolar lavage, the prevalence of the macrophages, which are the most relevant and represented population with a small amount of neutrophils. As soon as an RDS occurs, you have classically an inversion, a dramatic inversion of this proportion, where the neutrophils plays a really relevant role. Now, with the help of this cartoon, I want to investigate together with you the reason why we see differences at the bedside in terms of compliances and in terms of alteration of the gas changes. This is representing a normal alveoli, but as soon as you have the RDS, there are a number of alterations that appear and may cause some of the symptoms that we may detect at the bedside. Indeed, you have a sludging of the bronchial epithelium, as well as the deposition of hyaline membranes. But you have always to consider that the two elements of the alveolus, that are the capillaries and the alveolo per se, go together. And indeed, what happens into the capillaries, that the inflammation process activates the neutrophils, and you have also the activation of the coagulation with the deposition of platelets inside the capillaries, and you have just a damage, an injury to the tight junction of the endothelial. And then you have a migration of the leukocytes from inside of the circulation within the interstitium. And this goes together with an activation of these neutrophils and the cause of edema. The vascular thrombosis is one of the determinants, together with the increase of the edema, of the vessel compression and increase of the pulmonary pressure. So one of the reasons why at the bedside we can see an increased pulmonary pressure is related to this phenomenon. At the same time, the edema that is in the interstitial level, and that is determines a widened edematous interstitium that decreases the diffusion of oxygen and causes one other element for altering the normal gas change. But the activated leukocytes and the macrophages inside the alveoli started to be very active, liberating a congerie of insulting substances, namely cytokines or leukotrienes or all the inflammatory substances. They are capable to activate even further the other neutrophils coming inside, and the neutrophils, on their part, also can liberate a number of different mediators. And there is also an activation of the procollagen into the interstitium. All these phenomena together with the edema increase the weight of the lung, and the number of open alveoli is reduced. At that point, we still have the option of recruit because we have a florid edema, and there is no real consolidation. But the process goes on, and there is also an alteration of the internal part of the alveoli with the pneumocytes that are completely deranged. But the nude epithelium is another cause for the passage of certain cells from within the alveoli into the bloodstream and vice versa. And this is one of the reasons why at times we have patients with pneumonia and you have a diffusion of bacteria into the bloodstream due to the alteration of the internal part of the alveoli. Going on with this phenomenon, the inflammation and infections worsens, and at this time there is the appearance of the consolidation without having the possibility of recruitment, because the lung is like the liver, is very well consolidated. And going on, the process continues. You may have an activation of the surfactant. You have, again, the deposition of hyaline membrane, and the pulmonary edema in the other part of the alveoli go on. The compliance is reduced, and you have, due to the edema and the consolidation of the other part, the alveolar collapse due to decompression. So we can distinguish different phases of this evolution. You have an early one where the alveolar wall damage, the flooding in the hyaline membrane, of course, during the first 7 days. And in general, you have reduction of PaO2 of the compliance together with a bilateral infiltrate. Then starts a proliferatory phase that lasts in general something in between the 7 and 14 days. And under these circumstances, you have an hyperplasia of the type 2 alveolar cell, together with the infiltration of myofibroblast and partial resolution of the edema, to be replaced by consolidation. At this point, the situation is similar to the previous one, with a low PaO2, low compliance, the bilateral infiltrate, and the proportion and the ratio between tidal volume and dead space is increased. And the final phase, which is one of the most difficult to be treated, is the fibrotic phase that in general occurs after 2 or 3 weeks, even though at times you may identify some fibrotic phenomenon also in the early phases. And when the fibrotic phase is extensive, you have a total loss of the normal lung architecture. And in this case, you may have, when this is something that we saw in the past, when the patients were not ventilated properly, you may say the real presence of bullae that were caused by inappropriate high tidal volume ventilation. But as soon as you have recovered from this condition, you have some protective mechanisms that are properties of our body capable to restore the normal function, which means that through the apoptosis of neutrophil, pinocytosis, the diffusion of protein through the membranes, or the activation of sodium, potassium, ATP-dependent pumps, or through the aquaporins, the pores that may drain the water out of the alveoli, step by step, you can restore a normal condition. All these things are quite difficult to be identified step by step through the definitions that have some limitations and some advantages. As always, you pay a price when you try to define things, because not always you can be 100% inclusive of all the different phenomena occurring during the time. But in this nice review, there are also some suggestions concerning the potential algorithm that we can follow in order to treat at several and at different moments our patients. I think that part of this will be discussed into the case discussion later on, and so I will stop here and I leave the podium to Giacomo, that is going to represent you the effects of mechanical ventilations on these conditions. Thank you for your attention.